My name is Berthold Pemp. I'm working at the Department of Ophthalmology in the Medical University of Austria General Hospital of Vienna. I'm a specialty mainly neuro-ophthalmology and retinology.
Tell us a little bit about your department and the type of research that they're currently conducting.
Our department is one of the largest in Europe. We are one of the largest hospitals in Europe, and we have many patients in all kinds of ophthalmological subspecialties. We are conducting very many studies in retinology, AMD, diabetic retinopathy, multicenter studies with new medications, intravitreal injections, and also academic research in various fields of our department. All the subspecialty departments have their teams with research fellows, residents, and senior ophthalmologists.
Tell us about the presentation that you made here at AAO 2015.
I presented a poster about neurodegeneration science in retinal pathology, mainly diabetic retinopathy. There are several papers published earlier that showed that inner-retinal degeneration is present in patients with diabetes in a very early stage, even before vascular abnormalities appear. So we try to look if these signs, early signs of neurodegeneration, also correlate to systemic signs of neuropathy in those patients. And therefore we conducted a cross-sectional study with patients with diabetes type 1 of a long-standing period. They all had only minimal or moderate non-proliferative diabetic retinopathy, and we made OCT with a high-resolution OCT, spectral domain OCT. With this technique, it's now possible to separate all the different layers in the retina, and we tried to look if there is any correlation to systemic factors of neuropathy, and for that we measured heart frequency variability. This is done with ECG recordings, and the RR intervals, the pulse beats, are analyzed with fast Fourier transformation analysis, and usually you see certain patterns with provocation tests. There are several kinds of provocation tests that are possible, and we selected a standardized change of position with lying down, standing up, and lying down again. And doing that, usually the typical pattern of response in heart frequency variability is seen. Now, in diabetes, this pattern is disturbed, and there's a parameter that can be analyzed out of the data, and we saw a disturbed parameter in the low frequency spectrum analysis of the heart rate variability measurement, and this was correlated to the neurodegenerative signs in the retinal analysis of OCT. So both these parameters are signs for early neuropathology in diabetes, and that was quite significant.
What were the key findings?
The key findings were significant correlation between inner retinal and total retinal thickness and volume, with that correlated highly with heart frequency variability changes in provocative test. So this heart rate variability pathologic results correlated highly to the decreasing retinal thickness, and mainly inner retinal thickness decrease.
Were you able to correlate changes in hemoglobin A1C with your findings, or is this something that you plan to do in the future?
We looked at that. The parameter HbA1c was not correlated to the neurodegenerative signs, but my impression is that this is a factor that changes a lot over time. If patients have year-long diabetes, HbA1c might go up and go down, but this was not correlated to the neurodegenerative signs.
So what you're saying is the neurodegeneration that you saw may in fact be an even earlier sign than aberrations in hemoglobin A1C. It may be a more sensitive measure.
I
Would
don't.
that be fair to say, or not yet?
I would say these are two different kinds of things. So HbA1c is a very good parameter for glucose control, of course. But we don't know yet if this has an impact on the neurodegeneration.
So the thing is, in broader diabetology, we know from the very large studies looking at micro and macrovascular complications that there's a strong association between hemoglobin A1c and nephropathy and retinopathy. So that's the reason why I ask this question is because the bulk of the literature looks at HbA1c in terms of those microvascular complications. But what you're saying is that this is a field that stands on its own, potentially.
Yeah, I think so. HbA1c may be significantly associated with nephropathy in diabetes, but these are patients we investigated on had only early signs of vasculopathy in the eye. So we also took parameters for nephrologic signs of damage, but these also were not significant correlated to the neuropathic signs we found.
Interesting. So what are some of the clinical implications of your findings?
The clinical implications may be that neural analysis of the retina may be an early indicator for diabetic changes in the patient. So usually this is not performed, and with the new devices in OCT we can do that, and there might be many patients that are not really that don't have present changes in diabetic microvascular musculature, and on the other hand they could have neurodegeneration. So we have to look at that, and there are works that showed also functional analysis by visual field or VEP are changed in such patients.
Are you studying these patients longitudinally?
In our case, I only had a cross-sectional study. Currently, we don't have a study in longitudinal design.
Is that planned?
Not yet.
Not yet. Let's talk about some of the other research that you're conducting in this field. Tell us about some of the promising avenues that you're exploring in allied areas.
Yes, I will be glad to do that. We have many patients with neuropathies of the central nervous system, like multiple sclerosis patients, and those are very interesting to observe with OCT because they also show signs for neurodegeneration, even if there is no previous optic neuritis, but also in patients with elapsed optic neuritis, we find significant changes after the event. So we also do tumor patients with tumors in the optic pathway, and these all can be observed with OCT, and changes in retinal nerve fiber layer and ganglion cells can be observed in those patients. That's very helpful.
Turning to the translational implications for patients, if you were to say in a sentence or two what patients can anticipate coming out of your work potentially down the road.
If a patient goes to the doctor and an OCT is available, I would advise to do that and to get this analyzed if there is any obvious sign for pathology in the retina. You could also have advanced retinal pathology like DME, but in the early phases of DME, neurodegenerative signs could also be analyzed with the OCT. So very early signs can be seen in OCT, not only edema but also degeneration, and this should be done in the clinics.
So would you say you would like to see your protocol adopted as standard practice for early surveillance in these patients?
As there is quite a variability in individuals, I'm not sure if it's possible to implement it for general analysis in patients. But nevertheless, if there's quite a significant change in one patient, this could be seen in this analysis. For the heart rate variability, this should be done in every diabetes patient.
Good point. Is there anything else that you'd like to share with us?
I think I'm glad that I had the chance to present this work in the Academy this year, and I'm looking forward to contribute to further meetings.
Dr. Pemp, thank you so much for joining us. Best of luck with your research, and we'll continue to follow your work.
Thanks a lot.